Welcome back. We will pick up where we left off with the respiratory system. And we had been talking about the non-respiratory functions of air movement, so speaking, yawning, sneezing, coughing, those types of things. And also, I had explained the Valsalva maneuver, what it's used for, but the risk of it for patients who have cardiovascular or respiratory disease, and that it can actually lead to a vasovagal response where heart rate slows down enough that the heart can actually just stop working. I want to pick up here now with the second part of the respiratory system and talking about measuring the ventilation rates and doing the test called pulmonary function test, PFTs. When pulmonary function tests are done, they're done by the respiratory therapist, typically in a pulmonology unit, or they can also be done sometimes at the bedside of patients that are in-house in the hospital. But there are different measurements that they're taking when they do these tests. And the thing to keep in mind for your patients, if you are in nursing and you're having bedside care of patients, is that no one has PFTs ordered unless they are in respiratory compromise. And these tests, while looking at what they're doing and how they do these tests, would seem not very anxiety provoking for someone who, has normal respirations. These are incredibly anxiety provoking for people who are already having difficulty breathing. So when someone is stressed with that, with oxygen deprivation and whatnot, and you're asking them to give their very last little breath into an instrument known as a spirometer that does this testing, then this can be really difficult for patients. So you should always kind of keep that in mind. But the reason that they're so important is that they can give a baseline for respiratory function in that patient and how much that patient is actually able to do at any given time. So there are lots of different values that are going to be measured. I am not going to ask, for our purposes, about the differences between these different volumes and capacities, but just understand that is what the pulmonology department, the respiratory therapists are actually doing, and trying to figure out for their patients, to figure out where their baseline is as far as how much that they can actually do. Again, you would want to know that the instrument that is used for that's measuring these is called a spirometer. Typically, when we have in-house labs and we're together with labs, we all do we do a few of these values on ourselves. I have a few spirometers that are of the grade that respiratory therapists use, and I get the students to do this, and even students who are pretty healthy and whatever, they admit that this can be sort of a difficult thing for them to do, some of these tests. I want you to, I have included this with your disorders table here, but this table is actually giving a few of the terms that are defining difficulty in breathing. Apnea is a temporary cessation of breathing, and most people have heard of that because they've heard of sleep apnea, where you, for very short periods of time, hopefully short periods of time, you stop breathing while you're sleeping. That can happen rarely, on rare occasions, and be kind of normal, but it should not be happening routinely. And the period that you stop breathing shouldn't be too long of a period. So if that is happening to people, they will sometimes put them on the positive air pressure machines, continuous positive air pressure at night. And probably all of you know someone who is actually being treated for sleep apnea. Dyspnea, dys as a prefix is always going to mean difficulty or labored breathing. EU as a prefix, EU means true, so eupnea means normal breathing. Hyperpnea is increased. Hyperventilation is also, seems sort of counter, it seems sort of like these are the same, but you can read through these. Hypo means low. Cushimal respiration is something that happens in diabetes mellitus. In diabetes mellitus, people are having to burn fats for energy, and that is changing their pH because of all the ketones that are being produced. So they go into ketoacidosis, and because of that, they are needing to do these deep rapid breathing that you can see them do. Sometimes it's subconscious, but you'll notice that they're doing that, and that is trying to get that pH balance back in the bloodstream. And we're going to talk about exactly that chemical equation of what is happening in just a second. We'll get to it in the slides. So, tachypnea, again, accelerated respirations. Respiratory arrest means the person has stopped breathing. So there is no noticeable, detectable inspiration or expirations happening. And then obviously emergency steps need to be taken to actually start breathing processes for that person. So that's obviously an immediate situation there. So I'm going to go past these because this is just for your information. You're not going to be tested on this, but please do keep in mind those pulmonary function tests, PFTs, are done to assess someone's pulmonary capabilities and their compliance. As we age, we understand that compliance decreases because the elasticity of the lungs are just not where they should be, and the respiratory muscles are weakened. Exercise can help to maintain that. So obviously people can build some respiratory capacity if they are active. Your body size makes a difference. People who are large have larger lungs. People who are small have smaller lungs. And this is why it's also important when people are getting lung transplants. You don't just have to do the tissue typing, which is the first thing you have to do, making sure that there's tissue typing is compatible or as compatible as possible, but also the size of the thoracic area and region. So they not only have to find a donor that matches, they have to find a donor that's the right size that this is going to work for. So controlling of breathing, we do not have to think about breathing. Thank goodness we have enough to think about. It's through the autonomic nervous system that this is controlled. And when we think about the centers of the brain, this is going to be the brainstem, the pons, and the medulla are both going to play a role in the respiratory control centers. When there's been damage to this brainstem area, this is when we see people who have lost the ability to be able to breathe on their own. So sometimes very high neck fractures, C1, C2, this can be high enough that it actually has damaged this area, caused damage to this area, and so the person would have to forevermore be on a ventilator. So these are the areas that we think about with respiratory control. The pons, this is the pons, and this is the medulla that we think about, and you can see this on your slides here. Making sure I haven't forgotten something I wanted to tell you about for unconscious breathing. Sometimes when people have had permanent damage to this area and are on a ventilator, people with broken necks that have survived the very high cervical fractures, sometimes they can go for short periods of time off of the ventilator, but they have to consciously make themselves breathe. So it has to turn over to voluntary control. So they can come off. Occasionally you'll have a patient that's able to come off the ventilator for short periods of time, but they have to think about every breath that they take and force that to actually happen. There is a deeper insight, I think, in your chapters about Ondine's curse. And Ondine, that was a mythology story that they took that from. But anyway, where someone has lost the ability to the autonomic nervous system to control, so they have to voluntarily control. And anytime they sleep or take a nap or whatever, they're going to have to go back on a machine for that. So this is where the input comes in, and this mentions the Ondine's curse. That is that happens. When we think about what air, just our normal atmospheric air, what it is composed of, it is approximately 20% oxygen. It's really a little lower than that. So about that much oxygen, about 78% is going to be nitrogen, actually. So nitrogen is going to be about 78% approximately 20% is oxygen, and the other 1+% are going to be CO2, carbon dioxide, CO2, but other, sometimes pollutants and other things that are in the air. So the predominant gas is nitrogen, with oxygen being the next most, about 20%, and that's normal. Too high of oxygen can be toxic. And this is why when someone is put on oxygen, it is a prescribed medication. It is a prescription, because it can sometimes be too high, and if it's too high, it's going to be neurotoxic, can damage the nervous system. So being put on oxygen is something to be considered and is necessary to extend life, often, and to save life. But it is something that needs to be managed as well, because there will be some potential side effects from that. Now, I think that this slide shows, it illustrates, if you think about this flask as being, this is the capillary, the blood running through the little capillaries under that football field. You would know what I mean if you listen to the first part lecture. And on top of the turf, if you will, but this is the air that has oxygen. O2 is depicted here as these blue little bubbles, if you will, of solids. So as the blood is moving through, oxygen will just naturally diffuse. It takes no energy, no ATP required, no batteries used. So oxygen will just diffuse until it's, balanced between the two areas, and it happens very quickly. If in this one, if you think about the little gray bubbles being carbon dioxide that is in the blood coming back from the cells that it is picked up because of aerobic respiration. It's one of the byproducts of aerobic respiration. The CO2 will unload into the alveoli. And again, that happens really, really quickly because blood is moving, and this doesn't take long to happen because the surface area is thin enough. There's one layer thick in the alveoli, one layer thick in the capillaries. It can happen really quickly. And so when you actually look at, I'm not going to ask you about seconds and how long it happens, but it does happen very quickly. Another thing to think about, certainly the concentration. So the steeper the concentration differences between the two, the quicker it happens. This diffusion that is happening, that is just passive, also depends a lot on the membrane thickness. So when someone has pneumonia is a lower respiratory infection in the lungs. Pneumonia thickens the membranes, and so it takes longer for that diffusion to happen, and this is what makes pneumonia particularly dangerous for the individual, is because of this difference in how long it is taking for the gases to exchange. So the surface area, I told you too, is incredibly important because they can only be exchanged when there is surface area. If you lose surface area, then you have lost the ability to exchange at that particular site. So this sort of leads us to this next slide that's really important. I want you to look at this top illustration where you see you could measure the surface area of these little membranes that have been sliced so that you can see. You could measure the membrane area, but you also see how thick they are, and this is normal. This would be a normal presentation. If you looked at a person with pneumonia, you can see the obvious thickening of those walls, which is going to decrease the amount of gases that can be transmitted in a set period of time, compromising the patient's respiration capacity, the ventilation capacity. So again, decreasing their oxygen perfusion, which is going to put a burden on all the rest of the systems. A person with emphysema, and we'll talk about what causes that in just a second. Air is getting trapped in these alveolar sacs, and because air gets trapped, it puts pressure on these one cell layer membranes, and they start to break, they start to pop. And as they start to pop, you've lost the membrane, and you've lost the blood supply underneath it. So now more air can get trapped and more pressure put on the membranes that are there, and more breaking and loss of membrane surface. Let me say this, and you would need to know. Emphysema is a progressive terminal diagnosis. What those two words mean is that when someone starts with emphysema and air starts to get trapped, it will break the surface membranes and you will lose them. And it will encourage more air to get trapped and more loss of membranes. So that's what progressive means. It's going to get worse. And terminal means that it will be fatal. Now, most of the time, people with emphysema end up dying from a heart attack instead of suffocation. But if their heart had lasted the pressure of trying to push blood around that wasn't oxygenated, the heart's having to work so hard in people with emphysema. If the heart lasts, then those patients would eventually suffocate. So, and some do. Some actually die from terminal emphysema because their hearts actually do keep going and keep trying to do. So it's really a horrific death any time that someone has not being able to breathe in air, that are suffocating in air. It's a prolonged, and it can be a very difficult death for them, but also for people who are watching. Oftentimes, they're so starved for oxygen near the end of terminal emphysema, they're going to be put on medications that make them not realize that they're suffocating, morphine, and those types of medications that will suppress their knowledge. Their brain is fooled that they're suffocating. They don't know they're suffocating. The problem with that is that all of those medications suppress respiration. So those medications accelerate the end and to a point that, and they also build tolerance. So you're giving more and more of those medications to keep the patient in comfort, at the same time knowing that you are suppressing their respirations and that will eventually stop their respirations. So emphysema, what causes it? Almost every case of emphysema that gets diagnosed is from smoking. So it's preventable. There is a rare amount of emphysema. It's very rare, and most of you will never know anyone that gets diagnosed with this emphysema. It's a hereditary diagnosis for emphysema, and people die from it in their early 30s, 40s, and it's a hereditary gene that causes them to not produce a certain protein called antitrypsin 1. Antitrypsin 1 is a protein that's found in the alveoli that kind of clear the alveoli. It's one of those things, that's protective of the lungs, the alveolar surface. So people with that particular rare genetic disorder, they don't have this, so that breaks those membranes because it's not clearing. But again, that's really rare. Almost all emphysema is from smoking, and it is preventable. So emphysema is a loss of surface area. Pneumonia is a thickening of the membranes due to infection or inflammation. Most pneumonias are viral. So that means that viruses have been the cause for them. Some pneumonias are because of aspiration. So somebody may have aspirated something that caused them to have pneumonia. And then on rare occasions, you have bacterial pneumonias. Each of the different diagnoses for pneumonias will have to be handled differently depending on what their diagnosis is. The good news, if you're looking for good news for pneumonias, is that most are viral and most will be self-limiting. So most of the viral pneumonias will be self-limiting. Most, not all, you know. So we're seeing something very different with COVID. The CV2, the virus that we call COVID, that's very deadly. That's very deadly pneumonia. But most pneumonias are viral of adenoviruses and other types of viruses that are self-limiting. But we would want to monitor and support with the signs and symptoms of the person when they have those viral pneumonias. All pneumonias get treated with antibiotics. Now let me explain why that was a huge sentence to say. We talk about that antibiotics only work against bacteria, and that's true. But in some diseases, especially in the deep lower lungs, even though you know it's not bacterial because it's viral and you figured that out from all the blood work and whatnot, you still are going to treat with an antibiotic. And the reason being is the viral pneumonia has compromised their lungs and compromised some of their immune system because they're ill. So you're going to treat with the antibiotic prophylactically to prevent a bacterial pneumonia from being a secondary infection in that patient. So yes, there are some times that you're going to treat with antibiotics even when you know it's not bacterial, but usually only when it's an infection like deep in the lungs, close to the brain, close to the central nervous system, those types of things, so that you can prophylactically prevent a bacterial infection from jumping on top of and adding insult to injury. Bacterial pneumonias and fungal pneumonias are much more deadly than other pneumonias. So you do not want someone who has just gotten over a viral pneumonia to all of a sudden, because of their weakened state, to get a bacterial pneumonia, because that mortality rate, the number of people expected to die from those, is much higher. Okay, so that's that. Now, one of the last things I'm going to talk about is probably, some students feel like this is the most difficult to sort of get their head around, but one of the last things I'm going to talk about is actually the idea about that you are breathing, as long as there's, as long as everything's normal, you're not underwater, you're not being suffocated, you don't have emphysema, you're just walking around, you're normal in a normal environment. As long as everything's normal, the reason that you are breathing at the rate you're breathing, your respiration rates, is to control the amount of hydrogen ions that are in your system. That means controlling pH, because that's what that means. pH is defined as understanding how many hydrogen ions are present, right? So the entire respiratory system is a major organ system to control pH. And how it does this is this, and I hope you'll stay with me on this as I'm talking about it. You all recognize these two reactants together. You recognize CO2 and H2O. You recognize them because they were the end products of aerobic respiration, right? Your trillions of cells, all of your cells, are carrying out aerobic respiration. And when they're carrying out aerobic respiration, those cells are giving off as byproducts, as waste products, CO2 and water. So think about your trillions of cells pumping CO2 and water out. Well, you have to have a mechanism to take care of that. And you do in your body, and there are actually several mechanisms to take care of that. But in your body, you're going to have enzymes that will convert these elements into carbonic acid. This is carbonic acid that I just highlighted. Now, it probably would make sense to you that you don't want carbonic acid building up either. You don't want that happening. And again, these little arrows are very important. If y'all remember me talking about the fun part of chemistry is not really the elements and reactants and end products. It's really the story that's found in the arrows. But anyway, so this is bicarbonate. This is carbonic acid. But what it's going to be done quickly is converted to bicarbonate. This is bicarbonate, which is sort of an innocuous substance that we can use in our body, bicarbonate, and hydrogen ions. Hydrogen ions. Measuring the amount, knowing the concentration of this is what we said is pH. And we want our pH to be just right. Blood needs to be at 7.35 as the low to 7.45. So we vacillate around that. And one of the major ways that, and the quickest way, is by changing our respiration rates. Because if our respiration rates are slow, maybe down to 12 per minute, which is the low normal, this will be building up. And as it's building up, hydrogen ions will be being produced and pH will be dropping. Remember, the more hydrogen ions you have, the lower you are on the scale. It's inversely proportional. pH is the negative logarithm of the concentration of hydrogen ions. We covered that at length in AMP1. So you're becoming acidic. Not too acidic, just a little bit, like down near 7.35. And that's okay, because as soon as the nervous system detects that you're getting down towards 7.35, which is more acidic for blood pH levels, your respirations will just increase. And as your respirations increase, these arrows will turn the other way, and you will blow off CO2 and water. Every time you breathe out, you're breathing out CO2 and water, and other things as well. But the CO2 breathing out expiration is really for getting rid of CO2 and water. And when the arrows have moved the other direction. And so when you're breathing out CO2 and water, you know that you're getting rid of the hydrogen ions, which means that your pH is coming back up, staying within the normal range. So again, this is really kind of an important thing for you to realize. So as CO2 is loading into your cells, you're getting a little bit acidic. That's okay, because then you're just going to get rid of it by breathing it out. Breathing it out in the form of CO2 and water. So the rest, again, there's all kinds of illustrations for you to sort of see this. But the respiratory system's, one of its main functions is controlling that hydrogen ion concentration, which is essentially pH. Now, in doing that, it's also controlling CO2, obviously, because we saw this carbonic acid pathway here, and so we understand that. But that's the major function of the respiratory system. The beauty is that in the process, you're also delivering oxygen to your cells. So you're getting oxygen to your cells, which they absolutely need for aerobic respiration. Remember, glucose plus oxygen inside of your cells gives you lots of ATP, but at the same time gives off CO2 and water. That was our synopsis of that little aerobic respiration equation. I think most of you had me for AMP1, so you are very familiar, or should be, with this, and so you realize that this is just really kind of a beautiful system. So our respiratory system has a way of getting rid of the CO2 and water that the trillions of cells are putting off as a byproduct of making energy. So we have chemoreceptors that are monitoring pH. They monitored the pH, they're monitoring these levels, and as I said, the nervous system detects when pH gets too low at 7.35 or is too high at 7.45, and it keeps us back in homeostasis. So the nervous system, this is why it's so important that we keep the nervous system working. We don't do anything that's going to overexcite it. We don't do anything that is going to depress it. We need the nervous system functioning because it is controlling all homeostasis for every system. When we think, and again, this is explaining to you that the pH of the cerebrospinal fluid is the most powerful stimulus, as long as everything else is okay. When we think about acidosis, that's going to be a pH of less than 7.35. And, you can take a look at some of these slides. They've just talked about exactly what I've been talking about. Alkalosis is greater than 7.45. And again, you can look at some of the things that would cause imbalances of this. Again, acidosis, respiratory acidosis is going to be corrected by hyperventilation, just breathing more. Your breathing rate goes up. This is why if you measure somebody's respiration rates, inhale and exhales per minute, it might be 12 right now, but in 10 minutes from now, it might have gone up to 16, and 30 minutes from now, you might see it near 20. But it's the body's autonomic nervous system controlling this hydrogen ion concentration by either slowing your respiration rates down so that your pH can drop back down into normal, or speeding those respirations up so that your pH can go back more toward the alkaline. So I hope that, make sure that you get your head around that and you can answer questions about that. They can also have metabolic causes. So when we think about metabolic causes, it can be because of diabetes. It can be because of drugs. Different drugs can actually end up affecting the pH, so there can be many different reasons for it, respiratory and or metabolic reasons. Oxygen, we said, has little effect unless you're hypoxic, there's something causing the low oxygen. If you have emphysema, if you have pneumonia, maybe you've been in higher altitudes where we know the concentration of oxygen is lower than at sea level. So all of those things could actually lead to it. Hypoxia, so low oxygen. And we understand the ABCs of health, right? Airways, breathing, and circulation. It's all about, we do need, oxygen to all of our cells. And without it within minutes, there's going to be problems happening at a cellular and tissue level. So this is, certainly, I'm not trying to make light of what oxygen does. We've got to have it, and minutes do make a difference. There are different reasons for it. When we think about hypoxia, it is usually because of inadequate gas exchanges. So like higher altitudes, drowning, you've aspirated something, some liquids, and it can even be like stomach acid. It can be anything that you've aspirated into the respiratory system. You're in respiratory arrest, lung diseases, carbon monoxide poisoning. Carbon monoxide has a higher affinity for the iron and hemoglobin, and I talked about that in hematology, than oxygen. So it actually just replaces oxygen and takes over that hemoglobin, and it's very deadly, and it can be deadly in a quick hurry for that reason. Ischemic means there's not circulation. So something has impaired the circulation. And again, several different things can actually do that. We can have crush injuries. We can have some sort of compromise to the circulatory system because of diabetes. There can be a lot of different reasons. Anemic hypoxia is because there's not enough red cells or hemoglobin in the red cells. Histotoxic means poisoning. There are quite a few poisons. The sign that we see when this is occurring is cyanosis. That's when there's a bluing of the thin skin, like around the lips, the nares, the nostrils, fingertips, extremities. So you're going to see a darkening, bluing, purple darkening of these areas. This is cyanosis, and that is saying that the tissues are being compromised right then. So something's got to turn around as far as oxygen levels go. If it's allowed to continue, the effect is going to be tissue death. Necrosis is pathological tissue death, and the organs with the highest metabolic demands are the ones first affected, which is the nervous system. And there's no good news about that. So oxygen imbalances, you can also have too much oxygen. And I told you that this is a prescribed medication, oxygen is. And you do have to be very careful with it. Oxygen creates free radicals, which we know can lead to metabolic changes. It can lead to cellular decline and metabolic changes. destroying these enzymes that are necessary for cell function. It can permanently damage the nervous system, leading to seizures and coma. Hyperbaric oxygen, the full tents are really no longer used, but they still are using select areas, like for tissues that have gangrene or whatnot. They are continuing to do that. So chronic obstructive pulmonary disease is COPD. COPD, make sure you know what that stands for. The two predominant ones are asthma and emphysema. The World Health Organization just added a third one. The third one is obesity. People with obesity, again, we said lungs have to be able to change size and shape for air to be able to move in and out. If they can't change size and shape, air can't move. And over time, this has cumulative effects. That is an obstructive disorder. So when we think about COPD, things that are chronic, that stay with you, that you kind of always have, this can lead to chronic bronchitis. And bronchitis is seen in any of these. Chronic bronchitis can be seen in any of these situations. People with asthma are much more likely to have chronic bronchitis. People with emphysema definitely do. They used to always treat this with antibiotics, and thank goodness they know now not to do that. It's only on extenuating circumstances that they would actually use antibiotics for chronic bronchitis now, because it isn't from bacterial infections, but sometimes if somebody has it too seriously for too long, then they will prophylactically, again, talking about prophylactically using antibiotics to prevent something else from happening later. But anyway, emphysema, I've told you the cause for that. In case you missed the cause for asthma in the lymphatic system review, asthma is due to allergens, and it is reactive airway disease. Asthma is reactive airway disease that is due to hypersensitivity reactions in the immune system reacting to allergens that are in our environment. And we really shouldn't be reacting to them, but people with asthma have a hypersensitivity to them, and they do react to them, and their airways react by closing up. And again, every asthmatic event, every single one, is a life-threatening event. People who are diagnosed with asthma should always have with them a rescue inhaler, and it should be in date, and they should probably have two, just to be sure, and they should never go anywhere without them. The people that you will find that end up dying from an asthmatic event are the people whose family members said, but they were mild asthmatics. They never had, they didn't have serious asthmatic disease. And so guess what? They didn't have their inhalers. They weren't prepared. But every asthmatic event is a life-threatening event. ABCs of care, right? So the effects that chronically going without enough oxygen circulating around means that this is decreased pulmonary compliance. And what is going to end up happening is it does throw off your respiratory, it throws off your pH, which can adversely affect every organ system. It's stimulating erythropoietic release, so red cells are being produced when that's not really what was going on. So it can lead to polycythemia, which increases the viscosity of blood. It can increase the volume of blood. This puts a burden on the heart. So again, a lot of times people with COPD, it ends up being the heart that ends up taking the major brunt of this, and the heart is sometimes what fails first. Cor pulmonale is a very specific thing that is happening with people with COPD. It is causing a hypertrophy of the right side of the heart, right failure of the heart, and it's due to lack of pulmonary circulation. So cor pulmonale, a very specific diagnosis, hypertrophy of the right side of the heart due to prolonged effects from people who have COPD. You can see this on the autopsies of patients who died from, maybe they had a heart attack, but their diagnosis was emphysema. And when you look at their heart, their right side of the heart is absolutely the same size as the left side of the heart. Should that be that way? No, because that right pump should be sending blood to the lungs. It's smaller than the left systemic side, and we saw that when our study of the heart. So cor pulmonale is the evidence of the heart damage that is being done when someone has COPD. Smoking and lung cancer. Not all lung cancers are created equal. So I think many of you know by this point that cancer is just an umbrella term, but there are so many different kinds of cancers. Even within breast cancer, there's so many different types of breast cancer. And here we're seeing the lungs now. Within the lungs, different types of lung cancer. Squamous cell carcinoma is the most common, and you can see kind of where this begins. I'm not going to ask you that, but that's the most common one. Adenocarcinoma is another one. It starts in the mucus glands. But the most deadly, the one that is the most deadly and the quickest to take someone is small cell, also known as oat cell carcinoma. This is the least common, but it's the most deadly. The reason that lung cancers have such a poor prognosis, no matter what lung cancer, but especially that small cell, is that they have often metastasized, left the area where they originated, that's what metastasis means, before they're diagnosed. So it's already spread before they're diagnosed. And this one spreads incredibly quickly. So this is one that you sometimes hear about, and then the patient gets the diagnosis, and then just a matter of weeks, sometimes weeks, months, and the patient is not there. So if you look at the progression, the prognosis is really poor for patients living, and this is a combination of all of them combined. If you look at it was a healthy lung inside the person, but this is what a healthy lung would look like. So this person obviously died from something else, but a healthy lung should look like this. This is a smoker's lung. So a half a pack of cigarettes a day is considered a heavy smoker. There is no safe amount of cigarettes a day considered now to be a safe amount, and a half a pack is a heavy smoker, and you can see what it's doing to the lungs. This table I have for you on a separate little document, but it's also in your textbook. This was edition 8, and I know the ebook has gone to the 9th edition, but they're very much the same. But I also have this for you so you can actually see it here on the PowerPoints too. Rhinitis. Rhinitis is inflammation of the rhino nose area. So there are hundreds of viruses that can lead to rhinitis, cold viruses. They're in the category of rhinoviruses, adenoviruses, and syncytial viruses. They're family of viruses that cause what we call the common cold, which is self-limiting. Respiratory distress syndrome, you can actually see, this is obviously this is a serious event. It's very common to be fatal unless there's emergency care available. Pneumonia we talked about, where most of them are from viruses, but on rare occasions you're going to have bacteria, fungi, other things. We talked about sleep apnea. Tuberculosis used to be called consumption. It was a wasting disease, and it's from a bacterium, Mycobacterium tuberculosis. There's also a couple of other species of Mycobacterium. So now when people have active TB, we know it's bacterial. We know we can treat it. There are rare types that are no treatment is effective toward. So because we know antibiotics are becoming the bacteria are becoming more resistant to the antibiotics because of overuse and misuse. So we understand that, but this causes scarring, and we are seeing increasing incidences of these in patients that are immunocompromised, like patients with HIV positive status. So tuberculosis. Some other terms here, I think we went over most of them. Pleurisy is when the pleural lining that's encapsulating the lungs becomes inflamed, and pleurisy is supposedly, I've seen patients come in with this that are, it's very painful. They describe that any kind of movement, breathing, like taking a breath in, feels like a knife going through their chest because that pleural lining becomes inflamed, and it can take a little while for that to resolve. It can be treated and take a little while for it to be resolved. So this is the end of our respiratory review, and I hope you enjoyed that, and I will see you next time when we're talking about the urinary system. There will be a quiz on this section, on this second lecture, so good luck.